The following webinar was recorded as part of the original implementation of IWISH and has been made available for informational purposes only. Some portions of the original recording have been cut to ensure participants' privacy. References to the Lewin Group, implementation team, site liaisons, PHL, Google Drive, and some forms are not applicable to the demonstration extension effective October 1st, 2020. Terms and conditions of grantee's cooperative agreement supersede any information presented here. Please see the IWISH Operations Manual for the most up-to-date implementation information.
Today for our IWISH webinar entitled Fall Risk Prevention. We're so excited that you joined us today to learn more, not just about how to prevent falls, but even more about what causes falls and some tools and resources that are available to you to support your residents. As we go through today's presentation on fall risk, we want you to think about the following things. What is my role as a RWD or a WN in supporting an IWISH participant who experiences a fall? Also, how can I support participants in addressing fall risk factors in their home? And then finally, which programs or resources can I engage to support our efforts to prevent or reduce falls for our participants?
Thank you. One of the things that we want to help identify is what a fall actually is. I think for a lot of people, they'll think that a fall is only when you actually fall violently to the ground. You know, if you think about someone who slips on ice and falls flat on their back and can't move. But other types of falls are someone who may slip and put their hand and lower themselves to the ground. And the reason why we call this a fall as well is, one, you've gone from an upright position and somehow found yourself on the ground, but also could be a telltale sign that something else could be going on that led to this problem, whether it be a little bit of dizziness, some weakness, and if this is a recurring problem, of course, we need to pay more attention to it. And if you look at the statistics in 2015 alone, more than 1 in 4 older persons reported falling. So we know if there's 16 of you, well, 4 of you might be at risk for falling or have already fallen. And the main thing is to kind of be open and honest about it so you can prevent further falls from happening. With the next slide, we want to identify kind of 3 major risk factors that falls occur. One is the physical risk factors, and those things where your body's changing, whether it's a new medical condition, whether it be, let's say it's worsening knee pain, you've got a bad back, and now they're telling you the leg is not as strong as it was before. Those things are a little bit more challenging because it's a little bit out of your hands. You have to go see a doctor, you have to hope that they find the right problem, and then you have to hope that they give you the right treatment protocol. But the other 2, the behavioral and the environmental, those things that everyone can make a difference or change in their life. Behavioral risk factors are things that you do or don't do. And there's simple things and more dramatic things. For simple things, you know, if a therapist or a physician told you to use a walker or cane and your choice is to not use it, and they tell you if you don't use it, you're going to increase your risk for fall. Well, of course, using the proper equipment and following the proper instructions is going to help you reduce the fall risk. There's other silly things that we all do. It's kind of going into the same routine we did 20 years ago, but not realize that 20 years has passed by. You know, climbing to the roof and cleaning out the gutters, or putting up the Christmas tree outside, or some of these things that may seem like, well, I've done it well for the last 20 years, but what you may not realize is that the physical part, where your sense of balance, your vision, your ability to maintain your balance when there is some sort of insult has changed. So we want to just be mindful of resetting and reevaluating all the behaviors that we had that are high risk or totally fine. The environment, easy things, hazards that you might find in your home. I can only say that when I go to my mother's house, I can see all the things that we've accumulated as a family over the entirety of my life, and I must think, you know, there's certain things that they can probably get rid of, and I know my mom and dad don't want to because of the wonderful memories, but of course, if space is limited, the more you accumulate, the more hazards that you can have. And we'll talk about a different slide of just different easy ways that you can maintain those memories, but make sure that you have a very clear environment so you don't have any falls. In the next slide, the slide after that, there's certain physical risk factors that are going to leave you kind of higher risk. And this is kind of a general kind of framework for you to think about. There's a lot of chronic medical illnesses, arthritis, a stroke, diabetes, Parkinson's. And the thing about it is let's say you went into the hospital and you were diagnosed with a stroke and they tell you, hey, you're good enough to go home. You have to remember that your body has now reset. And you might have spent the first 70 years of your life dealing and approaching things a certain way. A subtle vision change, a subtle weakness can completely change the way that you approach things. So it might take a little bit of time for you to reset. Medication use, which we'll talk about, probably one of the things as been mentioned by the poll before is contribution, or is contributing to issues with dizziness and lightheadedness. Pain symptoms, and pain is looked upon as a problem where a pain issue prevents you from being active. If you're not as active, you're at higher risk for fall. Sleep, insomnia, and fatigue. Being sad or worried, and if you think about depression as a problem that can cause you to be less active, less likely to eat, contribute to fatigue, impair it with sleep, it's kind of not just a singular issue, but a multifocal issue. If I had to pick, excuse me, two main things or three main things that I would be most concerned about for people, one would be vision, and the other one would be the foot and ankle issues, and the other one would be muscle loss and weakness. And the reason why I bring those three things up is the fact that as when you have balance, your balance is made up upon three different kind of systems. One is your brain, the other one is your spinal cord, and the other one is your vision. So when you normally lose your balance, let's say you're about to slip on the ice, your body sends signals to your brain, meaning your spinal cord sends signals to your brain to say, hey, you're about to fall. It uses your eyes to look at the environment and recorrect so the fall doesn't happen. As you age, as you know that your vision is going to decrease, and when you decrease, you don't have the same ability to compensate and send the same correct signal back to the brain and the spinal cord. So as a result, your ability to cheat has been impaired. And so that's why it's very important as people start to have changes in their vision that we don't take it as an isolated issue that, hey, you can't drive or maybe have a larger print. It's more about making sure that your vision is doing its job in terms of sending the signal back to ensure that a fall doesn't happen. In the next slide, we'll kind of explore some of these issues going forward that we kind of touched upon. One of the main things that is really problematic for people as they age is the number of medications that they take. And I think anyone who's above the age of 65 or above the age of 70 as they come into my clinic has a laundry list of medications. And we've written classes of medications on the left, and the idea is that you're not supposed to learn all the classes of medication, but just lets you know that probably 1, 2, 3, maybe even 4 of your medications that you have independently can increase your fall risk, and then the combination of the two can kind of multiply the fall risk that can happen. Now, you want to make sure that it's not necessarily taking the medication, but it's also the changes. So if you have a sudden change in your medication, you want to ask your doctor right away, how will this change in medication affect my dizziness and lightheadedness, and for how long? So the main thing that you would want to do is you go and see your doctor, bring a list of your medication, and ask the question. These are my updated list of medications over the past year, because you might have 3 or 4 consultants putting in new medication. Ask which ones are contributory to fall risk, which ones, and then be honest about which ones give you dizziness, and see what things can be adjusted. A lot of times, easy things can make an adjustment. For example, if you have medications that are all given in the morning, sometimes the primary care doctor can say, well, why don't we do a third in the morning, a third at lunchtime, and a third in the evening at night, so you don't get all of them all at the same time. Sometimes medications aren't needed. If you're under a lot of stress and your blood pressure's through the roof and they start you on a bunch of blood pressure meds, well, when the stress gets better, your blood pressure is going to come better. So a lot of times I notice that people don't need as many blood pressure medications as they needed at one point in time. And a lot of the new guidelines regarding blood pressures have a much higher threshold to start treating in comparison to when you were younger. So for that, that reason, I think you can work with your primary care physician to figure out what meds are actually needed. And so just start writing down the symptoms, the feelings that you have when you take these meds, because there are a multitude of different alternatives. And I think the pharmaceutical company gets paid a lot of money to find different alternatives, so I think there can be good alternatives. The next slide. This is where vision is very important, and I know we touch upon the importance of vision, particularly as we use it to help maintain our balance and compensate for a potential fall. One of the other things with vision as well is, remember, all of us want to be independent, whether you're 10 years old or you're 100 years old. Changes in your vision can affect the way that you can drive, which can lead you high risk for having a car crash or a car accident, excuse me. But the same light, the way that you look in the environment, even if you're not having a fall, you don't want to slip on a rug because you didn't see it. You don't want to accidentally run into something because the lighting is dim. Different things that you can do. 1, get an annual eye exam after age 50. 2, make sure that you have a well-lit room. And then thirdly, you are consistent with wearing the glasses that you're supposed to wear. And different medical conditions can affect your vision. So if you have an issue with diabetes, once again, make sure you have your eye exams at least once a year. And then be mindful of when you're supposed to use which glasses. If you have separate reading glasses, make sure you're sitting down and using them, because once you are getting up to move, the reading glasses may not be helpful in helping you navigate the environment. And the thing that it comes off with cataracts or different visual issues, there's going to be a timing issue in terms of how you treat it. Don't be the limiting factor, and what I mean by that is, a lot of times if you go see a doctor, they'll say, hey, you've got this medical condition, it's not urgent, it's not going to kill you, just call me when it becomes a problem for you, and you just need to be open and honest about when it becomes a problem for you. Give me 1 second. Do you mind answering this for me? Thank you. Sorry about that. I saw my pages come to my phone. Next slide. And so blood pressures, and this is kind of an offshoot of the medication problem that we talked about. One of the key things is, there's the language in the first line says get your blood pressures checked regularly. What I would actually encourage everybody in this room to do is go get a blood pressure cuff and check your blood pressure at least twice a day. Particularly if you have issues with dizziness, make sure you check it on your own, because when you go see your primary care doctor, if the only time that your blood pressure is being checked is when you're being seen in any type of clinic setting, it only gives you a spotty amount of information that the physician has to use to make a change. And of course, as we know about white coat syndrome, you go and see the doctor, your blood pressure is 200 over something, and the physician says, well, we got to increase your blood pressure medication. And of course, when you go home, what happens? You're back to having normal blood pressure, and it's too much medication causing your blood pressure to go low. So write it down 2 times a day, 3 times a day, and bring that log in to show your physician so they can see how things work. There are other things that can happen as well. One of them is called postural hypotension or orthostatic hypotension. What that means is that when you go from a lying position to sitting or standing suddenly, your blood, pools in your legs. And when it does that, not enough of the blood goes back up to the heart, and of course the brain, and what happens is that you feel dizzy. Easy things that you can do is making sure that as you change position, you take your time. I always just tease my very religious patients saying, make sure you say your prayer before you get out of bed. It works twofold. 1, you have good blessing, and 2, it kind of helps buy some time for your body to get acclimated in the change in position. The other thing as well is, once you change your blood pressure, just be very vigilant about writing down how you're feeling from a dizziness perspective. Next slide. And additional risk factors, and this is more of kind of a theoretical thing that could end up happening, is that to make sure that there's a interaction between a lot of the different functions that you have in life. And the reason why I bring that up is if you have a new medical condition, you don't want to just say, well, it'll be fine. Understand that it can negatively impact a lot of different systems. So if you have a urinary tract infection, which may cause you to increase the frequency of urination, you might start going to the toilet every 2 to 3 hours, and that can lead you to have some physical fatigue. And then as we get fatigued, your fall risk could increase by the end of the day. So if you're noticing that you're increasing your frequency and you're being treated for the urinary tract infection, take breaks or start timing your voiding to go to the toilet every 2 to 3 hours on your own, or create a situation that can help reduce the fall risk. Or if you have worsening pain in the leg because your legs are swollen, you might just say, you know what, I'm going to take it easy while this new medication works to help remove the fluid. And then 1 to 2 weeks goes by, we're not as active, and then suddenly when you start to be more active, you don't have that same level of energy and endurance, and you can create a fall risk. So as these new medical conditions happen, make sure that you're being mindful of energy conservation and simple things to help maintain your good energy, both from too little energy and overdoing it. Okay. Next slide. Next slide, I believe. Great. One of the things about fear of falling is that once you have the fear of falling, you're at higher risk for having a fall. Some of that is pretty obvious. You're not going to get out of bed. You're going to limit the things that you're doing. So the key is going to be as confident as possible and keep yourself as active as possible. As soon as you start noticing that you're becoming a little bit afraid of falling, this is where seeing your primary care doctor would be incredibly helpful, because easy things that can be done is if there's a fear of, this blood pressure medication makes me dizzy, there you go. The physician can make the adjustment to eliminate the fear. If there's some sort of psychological issue that's related to something like, I'm fearful to leave my house because I was attacked one time, well, this is where a psychologist or a psychiatrist can be helpful in helping you deal with those emotions. Because remember, the moment that you have fear of falling and you're not as active, your socialization is going to decrease, you're going to have inactivity, your legs are going to weaken, and you're going to have that social isolation, all of which can lead to depression, which we really don't want to do. Next slide. And as we talked about the environmental factors previously, easy things that you can do is just make sure that you eliminate the hard-to-reach lighting. If you have other people that can give you help, maybe you can tell them to come in every 6 months to change the lighting. Fix the broken steps, get rid of the unsturdy stools, just be careful of slippery floors. Make sure you get rid of any rugs, throw rugs that can kind of lift up and cause you to fall. And then just get rid of any items in the hallway. There's certain things like things that you plug into the wall, or if there's children that come by to visit you, just make sure that everything gets cleaned up before they leave. I guess that would be the role of whoever mother it is. There's also, I think we're going to be talking about this in a second, the CDC has a STEADI toolkit that has really a lot of nice, easy ways that you can create a nice environment to reduce the fall risk in the home. Next slide. There we go. And so the risk factors that we can address, easy things. The lack of activity, easy solution, getting yourself into some sort of class to help you maintain activity, whether it be something pleasurable like going for walks with family or friends, dance classes, or just physical therapy. It could be literally anything, but I would just really focus on things that you actually enjoy. We talked about getting the home environment a little bit more rid of things that could increase your fall risk, adjusting making sure you're taking care of your vision, medication use, the emotional issues, of course weakness, and then the improper use of the assisted devices. These are all easy things that everyone can do to kind of reduce falls. To the next slide. So when you have your primary care physician And that's going to be the easiest thing that you can do is to see your primary care physician regularly. I know it's becoming increasingly difficult to get in to see your primary care physician in a reasonable time, so you want to make sure that you come prepared. The primary care physician can evaluate your gait, your strength, your balance, and review your medication. But I think the easiest thing that you can do, and there is a toolkit that we're going to be talking about in a second, but to really identify where you feel like your fall risk is coming from. If you really feel like it's a fear of falling, you can tell your primary care doctor, listen, I really need to see a psychologist. Easy referral completed. If you feel like it's a dizziness with change in position, you tell them, look, I need to adjust my medication, your blood pressure medication. If you're having horrible pain issues in your knee, foot, ankle, they can send you to see an orthopod. If you feel like, you know what, my balance is just off. I don't know what it is, but it's just off. They can send you to either see a rehab specialist or they can send you to see a neurologist. But really helping them identify what the problem is can really help guide the fall risk prevention, and particularly because I know doctors nowadays only get 15 or 20 minutes, so we have to be very quick with the evaluations. The other specialists that you can have with the ophthalmologist with your eye, there's also therapists who can help you. An occupational therapy can do a home assessment and give you recommendations such as should you be using a shower chair, should you have grab bars in the bathroom. The physical therapist can help talk about what's the safest way that you can travel, whether it be using a cane, a rolling walker, maybe telling you, you know what, you can walk for about 5 minutes, but after that you got to take a break. So a lot of easy ways, easy strategies that you can get from a lot of the consultants. And one of the things that they talk about here is about vitamin D deficiency. And just to expand on that very quickly, what they're really getting at is that, if you go to your primary care doctor and you know you're at higher risk for fall, the main thing you want to protect are your bones and your brain, right? And so to protect your bones, the concern is going to be if you have something like osteoporosis where your bones are brittle, higher risk for a fracture. So you can tell your primary care physician, should we check for osteoporosis, which would involve checking for calcium and vitamin D levels and checking a DEXA scan, which is a fancy test that helps check the density of your bones. So if you do have osteoporosis, which is another word for brittle bones, you can get the proper treatment so your bones are as strong as possible, just in case you do have that unfortunate fall. Next slide. And this is a link to a study, which is Stopping Elderly Accidents, Deaths, and Injuries. That's the acronym. There's a lot of really great resources, and we can talk about a couple of things. Many of them are included in this presentation, but I really encourage everyone to go and check it out. Coming from the home safety evaluation, different things that if there are administrators at the institution that they can use some of the checklists to go and talk to the residents to see if they're at higher risk for fall, maybe getting an early physical therapy evaluation, earlier primary care evaluation would be helpful. Next slide. I think this is where this is in the halfway point of the presentation, I believe, but we want to hear from you regarding some strategies that you all have used to help reduce falls, or if you had a question, I think maybe this might be a time to ask those questions.
Yes, thank you, Dr. Ravi. Just a reminder to everyone, you can either type into chat, or if you raise your hand, we'll unmute you so you can speak via the phone. We just want to hear from you all. What are some strategies when residents have a fear of falling? They talk to them about their medications and about the importance of how to change positions, so standing up slowly, and how to keep balance as you sit up or stand up or sit down. Anyone else have any strategies that they use or have used successfully in talking to residents about falls? All right, Payshawn says, we've partnered with physical therapists and occupational therapists in the area who have come to do classes on falls prevention. Nice. And Lisa says the fall risk tab and the PHL assessment has been an effective tool for starting a conversation about fall risk and their personal experience around it. That's good. I like that you are starting a conversation, because typically when it comes to falls, talking about falls is not a one-and-done conversation. And earlier, it could be related to medication, so your medication may change. You might have a change in your medical condition. And so as you begin to go through various changes, it's important to constantly have that conversation about how to prevent falls. And Denise says, we had a Matter of Balance class this past winter, and we'll reschedule again. We also have a trauma unit from a local hospital present in December. Nice. Maintaining independence and framing has a safety measure. I like that. Thanks, Kathy. Keep chatting, you all. If we have time at the end, we'll come back and have some more Q&A and discussion.
Oh, we can just do the next slide. If a resident does have a fall, and sorry, I was speaking earlier, I was always speaking to the residents themselves, so I figured you'd know. So yeah, staff-wise, if a resident does have a fall, check for injury. I mean, I think the main thing that we always talk about is making sure they didn't hit their head or neck. Honestly, if anyone did hit their head, especially because we may not know what their we may know what medications are on, if they're on a blood thinner, they're at high risk for having a bleed in the brain, but we may never know if they're at high risk for having a bleed in the brain just from their anatomy, the platelet level, all these different things. So if they have hit their head, I would just err on the side of caution and just make sure we have an urgent evaluation, which may include a scan of their brain, which I know would require an ambulance to be called, but I always say it's better safe than sorry, especially as you age. There's just higher risk. And of course, I would say, call their doctor if you have any sort of issue. I think the main thing is, if they have suffered even one fall, just get them set up with their primary care doctor, so there can be a discussion, a review of medication, a discussion about what simple things that may have led to their fall. And honestly, I don't think seeing a physical therapist would be a bad thing for twofold reason. One, they can do an assessment to see if their balance is off with some of the tools that they use. And then, of course, just simply to teach them how to get up safely if they have suffered a fall. Next slide. Oh, next slide. Oh, thank you. Now, when you're using some of the STEADI screens, you can really it can really help create and it's on the next slide, and then we'll talk about it. It's a really nice slide to kind of encompass all those subtle issues that may be telling you that this person is at high risk for having a fall. But you can really just, and we can actually go to the next one because I think it'll make better context. So if you just go to the next slide. If you look at this, I know the font is really small. The questions are, have you fallen in the past year? Have you been advised to use a cane or walker? Do you feel unsteady when you're walking? Do you use the furniture to maintain your balance? Are you worried about fall? You have to push your hands into the cushion to stand up from a chair. Difficulty stepping onto a curb. You have to rush to the toilet. You have loss of feeling in the feet, which is very similar to, this peripheral neuropathy, and then feeling depressed or angry. So this is such a nice tool, and I know that you guys all use it already. So I really like this tool as an easy guide. Now, of course, if it's coming up as being high, then of course send them to the primary care physician. The other thing that I like to look, if you look at the next slide as well, is very interesting about kind of the emotional state or the way that people kind of justify their falls, because we go through this all the time. I have certain patients where I'm trying to tell them, look, you're falling all the time. This is a medical reason why, and they just don't want to do it. They're in that pre-contemplation stage. So sometimes it just takes a while for them to truly accept. I think one of the things that I would suggest, if it's possible, I think for me as a clinician, when I hear someone having a fall and they say, well, it's fine, and you kind of want to take someone at their word, if you have got a good relationship with that person, you can always say, hey, I'd love to come with you to your clinician visit and really talk about things that I'm concerned about. And if you have a good relationship, at least you can tell the clinician, look, you know, they fell twice, and I really feel that they're really not accepting that how important it is, because they have too many falls where they're going to go from living independently to living in an institutionalized setting. And that might be an easy way for you to bridge a gap if they're at the pre-contemplation stage and you want them to be at that action stage. And so the resources that's on that website really talks about ways that you can kind of strategize and speak to the residents about having them to recognize some of the fall risk issues that they may have. Next slide. Some of the easy things in terms of the environmental assessments, this is the one that I was talking about. It really goes through your stairs, your floors, your bedrooms, your bathrooms, just very easy kind of things, you know, such as, you know, wearing non-slip or having a non-slip rubber mat on the floors. They might be able to get shoes that have a little bit better grip. You know, simple things like making sure there's a phone near the floor in case they fall and they can't get up. I know that some people have it's kind of like a call light around their neck that they can hit and dial 911, keeping emergency numbers in large font near the phones, and the list kind of goes on. And you know, all we really need to do is kind of mix and match with who people are as people. So, and the easiest thing that we can do is just the flooring and the lighting. So what's above and what's below, just making sure we have a well-lit room and just we're clear of any obstacles. Next slide. And then one of the easy things that you can do, and if you ever want any clinician, I'd be happy to come and talk about wellness programming, but just really having education, because I think the more that people hear about it, they realize that this is not just them going through the experience, but a lot of other people that are going through very similar experiences, and goes into that sense of community that they're not the only person that's having this problem. And I know something someone had talked about, was it Matter of Balance or another organization where that came in and talked about fall risk prevention, and it's a nice group setting where people can talk about how they're emotionally feeling about their risk of falling. And that group setting and that camaraderie is really great because people can give their own kind of experiences and their strategies that they're using, because sometimes it's better for people to hear from someone else going through the same experience and someone who said, oh, I read in a book and this is what you're supposed to do. Really, you know, offer exercise programs, and there's easy things that you can do. The reason why I say that is, you know, whatever people's interests are, go for it. I mean, if someone has Parkinson's disease, for example, there's some great data that shows that the tango or dance rehab is incredibly helpful in helping that person maintain their reducing their risk of fall. So if someone likes dance, get them into dance classes. If someone likes boxing, you know, Parkinson's boxing is a new thing. If the list kind of goes on, I'd really just kind of focus on things that they like. And remember, if someone has pain issues, we can get them into aquatic therapy, which reduces the risk of pain over the joints that are already painful. And of course, it not only helps with the strength, but also with the sense of community and the socialization. Next slide. Oh, next slide. Okay. Is it? I'm sorry? Okay. Okay, I think that you guys skipped a slide. If you can go back one. There we go. So, you know, there's a lot of different exercises that you can do that are very simple. The simple ones that you can do is kind of a sit to stand that they're doing. That's on the chair rise exercises. The reason why this is actually really important for people, regardless of the diagnosis that they have, is as you age, you have this problem called sarcopenia, which means that it's a fancy word for your muscles getting weaker and weaker with age despite you being physically active. Even Arnold Schwarzenegger has sarcopenia, which means that his muscle is turning into fat. Not all of us can be as physically fit as Arnold Schwarzenegger when he's 70 years old. And so where a lot of the muscle weakness happens is in the core muscle, which is your stomach, your butt muscles, and the back of your legs. And those are the very muscles that help maintain your balance and help you stand up. So this chair rise exercise, for example, helps you address those very muscles and help you maintain the strength of those muscles. So if you do have an insult to your body, you're better equipped to maintaining your balance. Next slide. And of course, that's all in the STEADI website and the resources as well of different exercises that anyone can kind of help lead and people can do as a group. So, next slide. And then DMEs, the durable medical equipment. The easiest, the toughest part of my job is making sure that people are using the right equipment. It's really not about finding the equipment that they need. It's about the one that they feel comfortable using. There's a lot of emotional issues that go along with the use of durable medical equipment. As you know, the aesthetics are not always pretty, and you can't just say, well, we'll make it, in a color that you would like. I think sometimes just using a cane or a walker just gives a certain feeling about who they are as a person. So I think the main thing is trying to figure out a way that we can convince or ensure that they know the importance of using that durable medical equipment. We don't want it to be learned from having a bad incident. Of course, the durable medical equipment is not just limited to the use of a cane or a walker or a wheelchair, but when you use it. If we think about what we talked about with the vision of when we use certain types of glasses in different settings, it might be such where using a cane for short distances might be helpful, but a rollator, a rolling walker with a seat might be helpful when you need to sit down and take a break. And of course, when when you're doing your inspections or you're doing your conversations, see if you can check the condition of the equipment. Some equipments can be easily fixed or replaced after a certain number of years. Usually with canes or walkers, it's about 5 years for it to be billed through the insurance. But there's companies that are they're nice, and if you have something simple as a worn out part of the device, they'll help create language so a new one can be issued. So if everyone in the facility or the staff especially can see to making sure things are not worn, the screws aren't coming loose, or there's nothing uneven about a walker, for example, that'd be very important. And then make sure that the primary care physician does the same. Easy things that you can do is if you have any residents, they can even have a checklist about discussion about blood pressure, medication review, and durable medical equipment in terms of the condition. And if there's something wrong with it, send it through the primary care physician. And then, of course, there are some loaner closets as well. So some of these bigger companies, they want your business, especially when you guys are a big group. They know that making you guys angry would cost them a lot of money. And so if you need a favor for a person who's having a tough luck with getting a DME or it keeps getting broken, they do have loaner closets to really help people. Of course, the durable medical equipment can also involve the accessibility of the environment, so making sure you do have the proper shower chair or tub transfer bench. Often what I end up telling some of my patients is, just think about what you want. It probably does exist, so Google it. And that's the beauty of Google now. You might be able to find a company who has an equipment that might be helpful, and it just may be a cost associated with it. But if they can somehow get it billed to the insurance, well, fantastic, because a lot of these companies might create a unique device, but they say this is the equivalent of a tub transfer bench, which we can order through the insurance company and it can be covered. Because they're in the business of making money, so I'd like to use that to our patients' advantage. Next slide. Yeah. So easy strategies that we can do just to kind of wrap up. Just make sure the emergency numbers are in large print near the phone. Put the phone near the floor or wear an alarm device. Make sure vision is checked yearly, particularly if there's been any change in the medical condition, whether it be worsening diabetes, and if there is something that can be fixed, like a cataract or new glasses that are needed, make sure that there is a quick and timely follow-up, and to ask the question to the ophthalmologist about what is the timeline of when this can be definitively fixed. Making sure that you are getting up slowly after sitting or lying down, just because the blood does pool in the legs. And so I say, say a prayer, or just count to 30 or count to 20 or count sheep, whatever makes sense. And if there is a problem, that would be something that can be addressed with a primary care physician, particularly with the adjustment of blood pressure medications, which may be too high. Making sure you are using proper footwear. Socks and slippers without grips are slippery for people who don't have a high fall risk. So making sure that there's grip in some way, shape, or form is going to be helpful. Making sure that there is proper light in the area, just so you can see, because your vision is not as well as it should be. Of course, the things that we talked about in terms of writing down your blood pressures, so take it to your primary care physician, and then of course making sure you have regular exercise. And the regular exercise should be done by something pleasurable, but should really focus on getting the core muscles, the stomach muscles, the glute muscles, the butt muscles, and the back of the legs as strong as possible. The sit-to-stands are helpful, but things like dance rehab, boxing rehab, or anything else that the physical therapist can help identify is always helpful. And I think we have our next slide for a little bit more discussion if needed.
So our next slide is a chat slide. And so, again, we want to hear from you. Is there a strategy or program around fall prevention or a response that you'd like to share? And then also tell us, what has it been like assessing for fall risk? So many of you all are well into the stage where you are conducting the health and wellness assessment, and as part of that, as Dr. Kasi shared earlier, there is the falls risk portion. And so we just want to hear from you, as we come to close, just what has it been like assessing for falls risk, and then any strategy or program that you've used. I know in the chat some of you have mentioned partnerships with area schools to do presentations. A few of you are using Matter of Balance and Tai Chi. Are there any other programs or strategies that you all are using related to falls prevention? Again, you can type into chat or raise your hand over the phone to share your response. When going through the falls risk assessment, I've experienced that the resident becomes more aware of their behavior and then more willing to address it directly. Lisa, do you have any specific examples of when this happened, like a specific behavior that a resident was willing to change or didn't even realize that they had, and so they made changes to address?
Hi, Joy. This is Alyssa. I was wondering if I could hop in and help you. How are you? I was wondering if, while people might be typing in other things, if I could ask one of the people who talked about working with physical therapy students, if they could talk a little bit about what they did, what they came to the site and did in terms of education or programming, whether it's a one-time event, an ongoing relationship, or just wondering a little bit more about what the programming is. I think there were a couple sites that mentioned partnering with physical therapy students or Hey, Sean, I'm scrolling through the list. If you would be willing, could you talk a little bit more? You mentioned that you all partnered with physical therapists and occupational therapists.
Hey, Sean, I see that you typed in the chat that you worked with them previously. So I guess I too, like Alicia, I'm wondering, do they come and just do a presentation on fall prevention, or do they come and also do a demonstration of some sort? And what exactly do they cover if they do a presentation in their presentation? Fall prevention strategies. They do demonstrations on exercise. Okay. Thanks, Sean. They bring equipment that can help in the apartment. Oh, okay. What kind of equipment? And then, Erica, also you were saying that you partner with the university to do a 6-part series. Could you share more about the topics covered in that? Oh, there you go. First one was fall prevention. Then they highlighted physical therapy techniques with multiple diagnosis, diabetes, heart disease, COPD. Okay, interesting. They show residents how the FWW should be positioned.
Yeah, I like to think that, you know, the whole process should be streamlined, but I can only speak for myself. So if someone is established in a clinic, you know, I think if someone has a fall and we're able to identify, let's say it's kind of a blood pressure issue, you know, I think it's not unreasonable for the resident to call the primary care doctor and tell them, listen, I've been monitoring my blood pressures, they've been sinking low, I've been getting dizzy, can we cut the medication and we solve the problem right then and there? In the same regard, let's say that they're saying, you know what, I haven't been as active the last month and I'm falling more and like my fall risk screening is going up. I really feel like physical therapy would be helpful. I don't think they really need to go and see the primary care doctor, but they can at least explain what's happening and you can get a referral out of it. And the reason why I say that is I have patients that do that all the time with me, and I usually just tell them, you know, I create that scenario for them saying, I'm not going to see you for a year and I know you, so if you feel like you're getting worse after this disability, you need therapy, don't come in, call my office, just explain what you want to work on, and then I'll write the script to cover that. So during the clinic visit, that yearly kind of physical, just plant that seed into the clinician saying, you know, if I want to get physical therapy down the road in the wintertime, whenever, how do I go about this to make sense for you? And the primary care doctor can kind of help out with that situation. And sometimes they can write a script, and somebody, you know, sometimes it's only valid for 3 months or 4 months, whatever it might be.
Okay. And then once they get to the physical therapist determines sort of the sequence of what types of things they're going to do in the therapy and for how long.
Yeah, and it'd be very important, and this, you know, this is kind of something else I'll say, that we can't force the issue with the primary care doctor or the physical therapist. You know, my fears always with therapy is that therapy sometimes can get overused in the sense where you only have a certain number of sessions for the year. You don't want to blow it all in the first part of the year. A good experienced therapist will know that, and they'll say, you know what, you're going to go for 5 sessions, and sometimes my patients come back and they'll say, man, that therapist was so mean, they kicked me out after 5 sessions. And I say, wait, you know, did they tell you about what the rules are with Medicare? And then you have to kind of explain to them. So you just want to be careful that we're not just blindly ordering that. But the physical therapist will do their assessments, kind of ask them what their balance issues are. They have different tools to kind of help identify if it's a inner ear problem, a visual problem, or just simply a muscle weakness problem, to create that kind of recovery program, so to speak. if that doesn't work well and they come back to you saying, you know, I talked to my primary care physician, I talked to the therapist, then that would be a time for you to get that second referral or that secondary level of assessment from either a rehab specialist, which is what I do, where they kind of go through all the person's day-to-day life, kind of talk about how their disability is affecting all of those day-to-day life activities, and then creating a fall risk like a program, or a neurologist. The neurologist might do more of neurologically what's going on. Is it nerves that have been burned off, or whatever it might be that's causing the falls.
Okay. Now, would a primary care physician refer directly to you, to a rehabilitation specialist, without going through therapy?
Yeah, they can definitely do that as well. It just depends on where you are. I know, like, physical medicine rehab is not as well known of a field, so if you do have a rehab specialist close, yeah, they can definitely do that referral. Of course, you know, if a resident is getting antsy, there's no reason, like at least the way it's worked for me, I think some insurances require referral to be given by the primary care physician, usually with some of the county care insurances, the governmental ones. But when you have Medicare, you can just make an appointment with a neurologist or whomever. It's just a matter of time to get that appointment scheduled.
Well, you know, just to give you a little more insight into the IWISH staff, what's so perfect about them is they can assist with these conversations and these monitoring in many of the ways that you suggested. So, for example, the wellness nurses on site are available to regularly help people with monitoring their blood pressure, and they can create those logs for them. So they can do exactly what you said about helping them monitor their blood pressure in their regular living environment, and then taking those logs to the doctors. Or they can either help them prepare to talk to their doctor about these different kind of risk areas that you mentioned, or they can get on the phone with them and actually, you know, assist them and guide them in a conversation with their physician, and making sure they really are prepared to tell them their concerns. So it's just a great value of this program.
Nice.
Thanks, Alicia. Did you have any other questions, or did any of our IWISH staff members have any additional questions for Dr. Ravi? Words or final tips for our IWISH staff members?
No, I mean, you know, it's just I mean, it's obviously it's an ongoing process, and I think having the conversation, which is what it seems like all the faculty are doing, is kind of the starting point, because once people start talking, they don't necessarily stop, and then you notice a lot of things that are going on that they failed to share with you, and it's just a matter of getting the resources and then making sure they have a good team. And what I mean by that is, you know, it seems like, you know, everyone that's on this phone line, I would assume, actually cares. And we know that in every field, there's people that care and people that don't care. It's true of physicians, it's true of lawyers, engineers, whomever it is. And so, you know, if, you know, really emphasize, you know, the people that are working with your residents, make sure that the residents feel that that doctor cares about them. And it might seem like it's a simple thing, but, you know, a lot of times I notice that falls can happen when people aren't listening to they're not listening to that person telling them, listen, my pain is terrible, or I don't feel great with this med, but you keep telling me to take it, but I really don't want to take it because I feel like crap, you know, because we all, just sometimes not listening is the problem. So just make sure the residents feel that their voice is being heard by the people that are supposed to be treating them. And if they are, then that's kind of a good sign, because they're gonna at least try their best, and then send them to see whomever needs to see them to kind of get answers to some of the problems.
Thank you. Thank you very much.